Welcome, veterinary students, to this high-yield clinical explainer. Today, we're basically stepping into the role of clinical detectives. Our mission? Hunting down the exact mechanisms and those all-important pathognomonic signs of non-metal poisons. You know, these are the toxins that absolutely won't show up on a standard heavy metal screen, but they can devastate a whole herd before you even know what hit them. So, grab your mental notepads because we are diving deep into this clinical toxicology dossier. This explainer is brought to you by Rockademy, and it's designed specifically as a high-yield clinical and exam guide for BVSC and AH students. We're going to set a pretty fast, energetic pace today. We want to master this material not just to absolutely ace your board exams, but, to actually save lives out there in clinical practice. All right, here's our clinical syllabus for today. 1. Targets and exam focus. 2. Fluoride and selenium toxicity. 3. Phosphorus and sulfur toxins. 4. Nitrate and chloride oxidizers. 5. Blood color and treatments. And finally, 6. A rapid-fire exam review. Section 1. Targets and exam focus. Differentiating pathognomonic signs. Okay, so to play clinical detective, you really need to know your lineup of suspects and exactly what their primary targets are. We've got fluoride, which targets skeletal and dental matrices. Selenium hits keratinized tissues and neuromotor function. Phosphorus just destroys the liver and jawbone. Sulfur acts on the rumen flora and GI tract. Nitrate and nitrite, well, they literally cripple the blood's oxygen-carrying capacity. And finally, chlorate causes direct red blood cell oxidation. The secret to cracking any case on your exam is pinpointing the unique pathognomonic signs for each one. Let's break them down. Section 2. Fluoride and selenium toxicity. The tissue accumulators. So tissue accumulators are basically the silent builders. These are toxins that slowly stockpile in the body until the damage is already done. Let's dive into fluoride first. Where is this even coming from? Well, in India, the most common source is deep well water, which becomes toxic at around 12 to 19 parts per million. Animals can also get exposed through industrial effluents, think aluminum smelting or brick kilns, and from rock phosphate feed supplements, which, by the way, should never exceed 1% fluoride. Now here's a massive exam highlight. The bone sink toxicokinetics. A staggering 96 to 99% of absorbed fluoride is stored in calcified tissues. It literally replaces hydroxyl radicals right inside the hydroxyapatite crystal structure. Normal adult bone has about 1,000 to 1,500 ppm of fluoride, but toxic bone? That shoots up to over 3,000 and sometimes even up to 5,000 ppm. So what does all that accumulation actually look like clinically? Well, the timing of exposure is literally everything, and that really illustrates the difference between dental and skeletal fluorosis. Dental fluorosis requires exposure specifically during permanent teeth development, which is between 1 and 5 years of age. You're going to see these chalky white flecks that eventually progress to brown or black staining and really deep pitting. If the teeth were already fully formed before the exposure happened, they mostly stay unaffected. Skeletal fluorosis, on the other hand, presents as a sudden onset of intermittent shifting lameness. You'll actually feel thickening and enlargement. Those are called exostoses on the sternum, mandible, ribs, and metacarpals. And palpating these bones causes the animal severe pain. Just a quick treatment note here, there's no specific antidote, but you can provide symptomatic treatment using calcium or aluminum salts to bind the excess fluoride right in the GI tract. Moving on to our second tissue accumulator, selenium. The environmental clues for this one are entirely botanical. We've got obligate or primary accumulators, like astragalus, also known as milk vetches. These plants literally require massive amounts of selenium to grow, accumulating up to 15,000 ppm. Now, they're highly unpalatable and animals usually only eat them during severe starvation, but here's your clinical clue. They emit a really distinct garlic sulfur odor. Next, we have facultative secondary accumulators like aster. These don't need selenium, but they will accumulate up to 100 ppm if it's present in the soil, and these are actually quite palatable. Finally, we have passive non-accumulator plants, like your standard crop grasses and corn. They can accumulate 1 to 25 ppm on seleniferous soils, and that's usually what's responsible for chronic poisoning. So, the absolute crucial point here is matching the exposure to the syndrome. Let's lock these exam keys into your brain. Acute toxicity happens with really high doses, and it presents with dyspnea, frothing at the nostrils, and sudden death. Your exam key here? Garlic breath, for sure. Subacute toxicity comes from moderate doses over a few weeks, and this causes blind staggers. The animal literally wanders into objects because their vision is impaired, even though they have a normal temperature. This comes with front leg weakness and paralysis of the throat and tongue. So remember, subacute equals blind staggers. Finally, chronic toxicity from long-term grazing causes alkali disease. You'll see cracking and sloughing of the hooves at the coronary band, loss of mane and tail hair, and emaciation. Chronic equals cracked hooves. Got it? Section 3. Phosphorus and sulfur toxins, the GI and systemic destroyers. Okay, these next toxins are aggressive, systemic destroyers, and their signs are completely unmistakable. First up is white or yellow phosphorus. Just a quick note, red phosphorus is completely inert and non-toxic, but white or yellow phosphorus is waxy, highly toxic, and commonly found in fireworks and rodenticides. This toxin has incredibly distinct pathognomonic signs. Acutely, it causes severe GI irritation, producing vomit that is actually luminous in the dark. No way, right? And it smells strongly of garlic. Plus, their blood turns black, tarry, and totally fails to clot because of severe hepatic necrosis. Chronically, it causes phossy jaw. This starts with a simple toothache and progresses to purulent discharge, deep necrosis, and sequestrum formation in the jawbone. If you see luminous vomit plus phossy jaw, it absolutely guarantees you're dealing with yellow phosphorus. Next, we have sulfur, which is often sourced from fungicides or excess feed supplements. Just a heads up for your exams, micronized sulfur is way more toxic than sublimed sulfur. Sulfur acts as a local irritant and a really strong cathartic, meaning it's a severe laxative that causes intense diarrhea, dehydration, and ruminal hypomotility or tympany. You might also spot polioencephalomalacia-like neurological signs, staggering, blindness, and convulsions. But what's the definitive post-mortem clue? The exact second you open the rumen, you're going to be hit with the extremely distinct smell of hydrogen sulfide. Yep, rotten eggs. Section 4. Nitrate and chlorate oxidizers, the blood oxidizers. This next category is a total classic exam trap, mostly because your differential diagnosis skills are absolutely critical here. Let's look at nitrate and nitrite. The environmental risk factors for these are all about plant stress, things like drought, frost, or even just cloudy weather, which actually reduces nitrate reductase activity. The mechanism is pretty straightforward. Plant growth stops due to stress, but the roots, they keep right on pulling up nitrogen from heavily fertilized soils. And the highest nitrate concentrations gather in the lower stalks, while the leaves and grains actually contain little to none. High-risk crops you need to watch out for include oats, corn, sorghum, and pigweed. Now, you might be wondering, why are ruminants specifically vulnerable to this? Well, it's all about a bottleneck happening right in the rumen. Rumen microbes use reductase to convert nitrate into nitrite, and then another reductase converts that nitrite into ammonia to make microbial protein. The bottleneck happens because the rate of reduction to nitrate is much, much faster than the conversion to ammonia, so this highly toxic nitrite accumulates and just floods the bloodstream. Non-ruminants and monogastrics lack this specific rumen flora, so they're generally resistant to nitrate, although they are highly susceptible if they ingest preformed nitrite directly. Once that toxic nitrite floods the bloodstream, it converts standard hemoglobin, which has its normal ferrous or Fe2+ iron, into methemoglobin, which features ferric or Fe3+ iron. And methemoglobin simply cannot carry oxygen. This leads to severe clinical signs of anoxia within a half hour to 4 hours. We're talking a rapid pulse over 150, severe dyspnea, tremors, cyanotic or muddy mucous membranes, and even abortion in pregnant females about 5 to 10 days post-exposure because of fetal anoxia. But if there is one ultimate pathognomonic buzzword you absolutely must remember for the clinic and your boards, it is chocolate brown blood. This happens when 20 to 50% of the hemoglobin is converted. But wait, nitrate actually isn't the only suspect that causes chocolate brown blood. We have to compare it to chlorate, which is typically found in inorganic herbicides and explosives. Both of these cause methemoglobinemia and brown blood, but there's a major exam key here. Nitrate relies on that indirect rumen mechanism we talked about, making ruminants susceptible. Chlorate, however, is a direct, strong oxidizing agent. Because it acts directly, all species, and that includes monogastrics, are equally sensitive to it. Furthermore, chlorate methemoglobin formation is slower, and get this, it actually continues even after the death of the animal. Section 5. Blood color and treatments, the diagnostic climax. All right, we've reached the diagnostic climax. You have your suspects, but now, how do we definitively test and treat? Let's recreate the clinical synthesis differential diagnostic using just blood color. When you draw blood and it's brown due to methemoglobin formation, your primary suspects are nitrate, nitrite, or sodium chlorate. But if you draw the blood and it is a bright cherry red, you need to pivot immediately. Bright red blood means you're dealing with carboxyhemoglobin formation from carbon monoxide or cytochrome oxidase inhibition from cyanide, where the tissues just simply cannot utilize the oxygen. Blood color literally dictates your entire emergency response here. And if you are dealing with that brown blood, methemoglobinemia from nitrate or chlorate, here is your treatment masterclass. The specific antidote is methylene blue. You're going to use a 1% solution in normal saline. The dose for cattle and sheep is 4 to 8 milligrams per kilogram, administered via slow IV. But heed this strict warning. Completely avoid overdosage. Excess methylene blue can directly oxidize hemoglobin itself, which causes Heinz body anemia. You really have to thread the needle to save the patient. Section 6, Rapid Fire Exam Review. Final polish. Let's lock in these crucial associations one last time before your exam. Get ready. Fluoride equals exostoses and mottled teeth. Selenium equals blind staggers, alkali disease, and a garlic odor. Phosphorus, that's phossy jaw and luminous vomit. Nitrate equals ruminant susceptibility, brown blood, and treating with methylene blue. Chlorate also means brown blood, but remember, it includes monogastrics and herbicides. And finally, sulfur equals a rotten egg odor and a severe cathartic effect. And that brings us to the end of this clinical explainer. Toxicology isn't just about memorizing endless lists. It's about observing the evidence, knowing the deep mechanisms, and reacting swiftly. So, which specific pathognomonic signs are you going to look for to crack your next clinical toxicology case? Take this clinical detective mindset into your rotations, and I guarantee you'll not only pass your boards, but you'll be the one out there saving the herd. Keep learning, keep questioning, and I'll catch you in the next clinical explainer.